Thank you. Thank you. Thank you. And thank you all for coming this morning. And I look forward to talking to you about this exciting topic that I'm sure that many of you, the reason you're here is because you're interested in faith and health. And I hear that you are starting a program on Sunday, the Faith Health Gaston Initiative. And so it sounds very exciting to me, and it fits in very much with what I'm going to talk about today. Now I'm hoping that, and we should have plenty of time for discussion, because I'm going to try to go through these slides as quickly as possible. One reason being because the discussion time is much more interesting than my slides that are a little bit highly scientific in terms of their content. So in any case, let's get through these slides so that we can actually start a conversation. So just a word about me. I'm a psychiatrist. I was trained as a family physician, then got interested in geriatric medicine and went through the fellowship at Duke of internal medicine fellowship for 3 years, then did psychiatry and geriatric psychiatry. I'm also a registered nurse, so that's probably my most important credential of them all. So in any case, that's it. And I see patients. I'm still seeing patients. I see patients about a half day a week, and then struggle with them the rest of the time. I see very hard patients, very difficult by the time they get to Duke and they get to me. They've been through just about everybody, and I'm kind of like the last straw. And so these are tough cases, and they're geriatrics, multiple medical problems, chronic pain, depression, anxiety, psychosis, dementia, all of it's together, So anyway, that's kind of my thing here. Now, how does one resume the slideshow? Do we have some hint on this? Because I'm not sure how that happens. But in any case, so that's what I do. But I do a lot of research. I really do a lot of research. That's most of my time is spent designing studies, carrying them out, teaching others to do studies, working with various faith-based health systems to integrate spirituality into patient care. So that's what I kind of do. So today, I'm going to talk a little bit about definitions, about the role of religion in coping with stress and change, review a little bit of the recent research focusing on depression. Depression is the biggest thing that people encounter. It's the most prevalent, particularly those with medical illness. Since I'm coming from a medical background, family medicine, internal medicine, geriatric medicine, a lot of my work is on depression in the medically ill. Depression in the medically ill. And there's plenty of it. Plenty of it as people get sick, disabled, all these symptoms. They have the changes, the losses. Depression, very common. So we're going to look at the role of religion and its role in terms of depression, coping with all of these health issues. Then I'll review some of the more recent research, talk about clinical applications, and provide you then with some further resources, okay? Including my new book. So I'll tell you a little bit about that. Okay, so in terms of definitions, you've got religion, and everybody pretty much knows what we're talking about with religion. But now my definition of religion is fairly broad. Okay, it includes not just going to church. Okay, it includes religion more broadly. Religious beliefs, practices, commitments, importance, centrality. Those are the kinds of things I mean when I'm talking about religion. But it has something to do with the transcendent. However you understand the transcendent, whether that be God, Allah, Hashem, a higher power, Or if you're in an Eastern tradition, that might be Vishnu or Krishna, Buddha, ultimate reality. Now, I do a lot of work with Middle Eastern countries. So I go to Saudi Arabia regularly, and I go to China as well. So if you have interest, I don't know as much about Buddhism. I know some, but not a lot about Buddhism, and a little more about Hinduism, a lot about Islam. Okay, so if you have any questions regarding Islam, this is the time to ask them. Okay? So, in any case, religion is often organized as a community, but can also exist outside of an institution, may be practiced alone and in private. See? So I have, again, a broad definition. Then there is secular humanism. Secular humanism views human existence without reference to religion, God, the transcendent. It has a focus on, rational things like science, and then, the role that the person or the self plays, and the community. So that's kind of where secular humanism is focusing in on, kind of like us, but not him or her, So that's basically it. Now then, spirituality. Many love the term spirituality, and I like it too. It's a nice broad term. It can refer to almost anything because people define it for themselves largely. That's the way it's currently viewed within the academic world. Okay, so spirituality is really, it can be anything. It can be a Duke basketball game when you're winning. That can definitely be spirituality. Or it can have something to do with the transcendent, but it doesn't have to. It can be much, much broader. Now, many people actually, define spirituality as a deep form of religion. Kind of the central, most important aspect of the religion is the spiritual aspects. Now, that is more the traditional definition of spirituality, where spirituality, those who are spiritual are actually are religious to begin with. That's a necessary, required component. Those who are spiritual are deeply religious. Like Gandhi or Buddha or Jesus. Deeply religious. So that's tradition. But with the current popular definition, you can be spiritual and not religious. So that's a big change. Big change. Only in the last 20 years or so. Okay. So that's that. Now, in terms of, because spirituality is such a broad term, hard to define, self-defined, everybody is spiritual one way or it's a nightmare for conducting research. Okay? Because research, you have to measure stuff. You have to have very clear definitions. Everybody has to agree on the definition. So we basically don't measure spirituality, we just measure religion. But religion broadly speaking. Broadly speaking. Okay. So Sigmund Freud had a number of thoughts about religion, and these then became the basis for how psychiatry and mental health care, as a psychiatrist, my colleagues, the basis being based on his views. So religion, he thought, was the universal obsessional neurosis of humanity. So if this view is right, it is to be supposed that turning away from religion is bound to occur with the fatal inevitability of a process of psychological growth. As we mature and we grow emotionally and socially and culturally, turning away from religion is bound to occur. He felt that it comprises a system of wishful illusions, based on the title of his book, Future of an Illusion, that together with a disavowal of reality, a refusal to accept reality, such as we find in an isolated form nowhere else but amentia. Amentia, it's another word for retardation. But also there's dementia, as you know. And so in a state of blissful hallucinatory confusion. So that's the basis for our mental health system today. And psychiatry. Sigmund Freud. Okay. And he was 82 when he wrote this. It's not like when he was young. He spent the last 10 years of his life writing on this kind of destroying religion. Moses and monotheism, he didn't care if it was Christian or Jewish or whatever. He was like against all religion. And he just one book after another. And Civilization and Its Discontents, all of those books in his last few years of life, he wrote. That was the topic of his last few years. Okay. So now, we know, though, that religion is often used as a coping behavior. People turn to religion when you get in trouble. I mean, what do you say when something bad happens? Oh my God! Or, well, even the vernacular, even if you're not religious, you're going to use religious terms when something bad happens. So it's used to cope with common problems in life, especially those that you encounter in medical settings or even psychiatric settings. Often used to cope with things such as uncertainty, fear, pain and disability, loss of control, discouragement and loss of hope. So this is, there's a lot of that out there, among our patients, among us. Things don't always go right in life. You run into some curveballs. And, we're all going to have to face this at one point or another. So, how common is religious coping? Well, if you were admitted to Duke Hospital in the 1990s, then the likelihood would be that there's a 40% likelihood that religion was the most important factor that kept you going. Was a 10 on a scale from 0 to 10. So this was a random sample of consecutive admissions to the medical, cardiology, neurology services of Duke Hospital. And it was a very simple study. We gave people this scale from 1 to 10, said circle to what extent you use religion to help you to cope. 0 means not at all. 1 or 2, a little bit. 5, a moderate extent. 7, a large extent. 10, the most important factor that keeps you going. So you can see here that 90% circled something above 5 on that scale. So I would suppose that here in Gastonia, you're going to have a whole lot of religious coping going on as well. Because, Duke is not just locally, it's more like internationally. So you have people from all over the place, New York and all over the country come to Duke for their specialty services. And even among those patients, 9 out of 10 use religion to cope. Now, usually though, that's not convincing enough for the people I speak to, which are, colleagues and medical doctors and things like that. So I have to say, okay, the New England Journal of Medicine. Does anybody know about that journal? And most people say yes. Even if they're not particularly religious or whatever. So, New England Medical Journal showed that after September 11th, 90% of Americans turned to religion to cope with the stress of the terrorist attacks. 90%. So this was a random sample of the U.S., not North Carolina. This is a random sample of the whole U.S., including Washington, state of Washington, and New York, Hawaii, Alaska. 90%, 9 out of 10 Americans turned to religion. That's how they coped with the terrorist attacks. So that's kind of hard now to argue that nobody is using religion to cope. Now, of course, this was about 10, 15 years ago. Maybe things have changed. Probably not that much, though, my guess. Okay, so does it make any difference? Yeah, sure, people say religion helps me to cope, or they report that, but maybe it's like Freud said, maybe it's neurotic still, maybe it induces guilt, guilt, excessive guilt, or anxiety. Maybe it makes things worse. How do we know? Well, we can study that. We can actually design a study, give out a questionnaire, people fill it out, do it randomly, and collect the data, follow people over time, and see what happens. It's very simple. It's, when I was a medical student, the way we learned what was true or not was by research. They gave us an article to read. We had to read it, and report on it. And so I thought, well, why not? I wasn't so sure about religion. You're a young person. You don't know, really. So I had heard various things. I've been to church and heard the preacher say it was good for you. Then I heard Freud. He said, it wasn't so good for you. So I was kind of a little bit conflicted there. I thought, I don't care what anybody says. I think we could just study this. Why don't we just ask people and follow them up and see if they're doing any better? That seemed to be reasonable to me. Made sense. You ask people, you could put people who are religious here, those who are not here, and watch them. Observe them over time. See who gets better, faster. So that's what I started to do. And now I wasn't the first person that did that. Many other people had done it, but not a whole lot of people in medicine. It had been mainly in psychology that there have been a few studies, but not much in the medical field. Because again, medicine and religion was separate. Medicine was scientific. Religion was all subjective and, just based on faith. It had nothing to do with science. It was the true source of truth in the world. So anyway, so that's the kind of community that I live in. And I know that my friend, I think you should sit somewhere close to this computer here. But in any case, no, that's all right. We could work it out there. Maybe I just have to do that. I could do that. Yeah, I could probably do that. Person from Duke could do this at least, Okay. So here's a systematic review of all of the research. Not just Duke. This is like everything by atheists and all over the world. This was in the Oxford University Press. Published this book. It covers thousands of quantitative studies. So now we're talking about real research, quantitative, measuring stuff. That's all it looks at. Because the model, the model of research has to do with quantitative stuff, things you can measure. Stories are wonderful. They're wonderful, and they attract our attention. And I love stories, but like the science, they don't care about stories. That's just one person. They want to see, what is it like overall? You might just happen to run into one very religious person. Okay, great. And the person, the world's oldest person, actually was from Atlanta. She was 114. They asked her why she thought she had lived so long. Everybody asks that question to hope you. Why do you think? She says, God. That's why I've lived so long. I lived the way He wanted me to. That was actually her word. I lived the way He wanted me to. And so I used to talk about that all the time. And then the next longest living person was a man. And they asked him the same question. They say, okay, why do you think you've lived so long? He was like 112 or so. And he said, wine, women, cigars, and smoking. So that was his answer to it. So how do you know? How do you know what? There are people, but of course they're selected out of a few million people that's anyway. Okay, so here's kind of a summary of the depression research. So depression, as I said earlier, most common emotional disorder found in medical settings. 40% of patients, 40%, 4 out of 10, have some level of depression once they're in a medical setting. Okay, so that's a lot of depression. Religious, and there have been 444 studies that have looked at this. 444. That was prior to 2010. There have probably been another 444 that have been published since then. But all we know is that on this systematic review, which was prior to 2010, there were 444 studies. Of those, about 2/3, 61%, found that those who were more religious had less depression and recovered faster from it. Okay, so some of that research was ours, but that was only like 2 or 3 of those 272 studies. So other people are finding this as well, not just at Duke. Now, 6% of studies found more depression. So the more religious you were, the more depressed you were. So that was some of the findings. Now, again, this is a systematic review, so that includes everything. There's not cherry picking just studies that are like agree with what we might hypothesize. This is like everything. So 61% versus 6%. So that's pretty good, in terms of. Now most people say, well, those are just paper questionnaires. People lie about how religious they are, how often they go to church. How do we know depression is something subjective? How do you know somebody's really depressed? How do you know somebody is really religious? They tell you. You ask them, they tell you. So it's all subjective. What about something objective? Something you can measure, something really not just measure, but observe. So, lo and behold, Journal of the American Medical Association, not a slouchy journal, is reporting in January of 2014 neuroanatomical correlates of religiosity. Okay, so now you've got structural MRI scans of people's brains. Now this is up in Columbia, Columbia University, New York. Okay, so this is not like Charlotte or somewhere down here in North Carolina. This is like New York City, Columbia University. So what they did was they looked at the relatives of people who had serious depression. Okay, so these are the relatives. These are not the people with serious depression, but their relatives, their children, their grandchildren. And what they wanted to do is they wanted to look at the brain structure of those who are at high risk for depression. And what they found was that those individuals, those children and grandchildren of those who had major depression, had brains that were different. It's a very, very famous study. The brains were different. The cortex was shrunk in many different areas. So the surface, the part of the brain that makes us uniquely human, the cerebral cortex and the frontal aspects of the brain, that there were multiple areas that were reduced in thickness or shrunk, basically. So they thought, wow, let's look and ask people and divide them up into those who are religious and those who are not, and see whether there's any difference in their brains. All of whom are at high risk for depression. Remember, these are everybody that's at high risk because they had a parent or grandparent with a major depressive disorder. Okay? So here's the finding out of JAMA. So on the right-hand side, this is the brains of those who are at religion. Very important, not very important. Okay, so the red are areas of reduced cortical thickness. Brain is shrunk. And see all this red? Not very important, very important. Right? Whole lot less red. A whole lot less. These are statistically significant areas of reduced cortical thickness. So if you want to, anyway, you're looking for objective evidence, here it is. Sorry. Okay. Did somebody have a question? Oh, by the way, I don't mind if you ask questions. in the middle of this talk. I don't mind. I'm going to be blazing through, but if you want, there you go. If you want to ask questions about this, I'm happy to entertain it. Either questions in the talk, in the middle of the talk, or at the end of the talk. So it's fine to do it anytime. Yes?
So these clients who have the diagnosis of a major depression on both?
Their parents or grandparents with major depression. So we figure the idea was that they were inheriting some genetic predisposition that resulted in the shrunken kind of brains. And maybe religious involvement led to an expansion of those cortices. Maybe. Now that the study didn't actually show that because the design wasn't able to show that, but it would be consistent with that religious involvement somehow changed the brain. Yes, there was a question over here somewhere. Anybody have a question over there? Okay, good. Okay, good enough. Don't hesitate to ask a question. The funnest part of this, remember, is the questions. Okay, so now, it also appears that even if you're depressed, even if you have a major depressive disorder, that the depression is different if you're more religious. It's just a different kind of a beast. So we looked at 121 patients with major depressive disorder. Everybody had major depression. That's how they got into the study. And we looked at the various levels of religiosity among those people in the study, those with major depression, various levels of religiosity, even though they all had major depression. We also measured, other than depression, positive emotions. Things like meaning and purpose in life, hope, optimism, generosity, gratitude, these positive things. We measured that in addition to the depressive symptoms. So this is what we found. Since everybody had, here's depression over here. This is depression symptoms, the severity of depression. This is the level of positive emotions. And this is the level of religiosity. So kind of the lowest level and then increasing. Since everybody had major depressive disorder, with increasing religiosity, there's no change in depressive symptoms. Because they've been selected into the study because they had major depression. So everybody's got a similar level of high depressive symptoms at about 25, 20, on the Beck Depression Inventory. But look at the level of positive emotions. Look how this increases with increasing religiosity. Even though they're all depressed, it's different. These individuals who are more religious have more positive emotions in there together with the depression. They've got more hope, more meaning and purpose, more positive stuff.
How do you define major depression?
Yeah. Major, we measured it using a structured psychiatric interview called the mini neuropsychiatric interview. It's called, it's a structured interview that assesses the duration and severity and functional disability associated with 9 depressive symptoms. So those 9 are sleep disturbance, loss of interest, depressed mood, weight loss, suicidal thoughts, cognitive dysfunction, difficulty concentrating, psychomotor retardation, all of those kinds of things. See? So this is the standard way of measuring a major depressive disorder. So everybody had that in this study. But they had these positive emotions if they were religious, yes.
And define religiosity.
Yeah, this was a multi-item measure, about 39 different questions. It included religious attendance, frequency of prayer, frequency of Bible reading, frequency of, the intrinsic religious motivation, to the extent to which religion was the central focus of the person's life, those kinds of questions.
It wasn't just Christian religion.
No, it wasn't. It was like any. It wasn't. It didn't even mention Jesus or Christ. It did mention the Bible. It did mention the Bible or other scriptures. It did say or other scriptures, and it's like in this study, like 90. Well, not that many. It was 80% of the patients were Christian. But 86% were Christian. 87%. So there were a few Buddhists and stuff in there. Actually, we had to change it for the Buddhists. We changed some of the items for the Buddhists. So we tried to cover all the bases. But, that's okay. Any other questions? Okay. Okay, so now, anyone who doesn't ask a question in the room by the end of the talk has to buy my book. Okay, that's your punishment for not asking a question. Okay. Now, a little bit on the religious psychotherapy study. Now, we figured, okay, well, if, people have, better looking brains if they're religious, if they have more positive emotions, even if they're depressed, if they're more likely to be less depressed and recover more quickly from depression if they're religious, then maybe we ought to use a religious form of psychotherapy to address depression, at least among religious people. It would seem to be reasonable. Now, this was our study. It was a major depression. The same people in the last, slide I was showing you. And most of them were over 50. They were randomized to either religious cognitive therapy or secular cognitive therapy. Without any mention of religion, if somebody brought it up, they kind of said, well, let's talk about this in terms of more universal humanistic terms. But the ones that got the religious cognitive therapy, they got a really, really Bible-based, not for the Christians, they got a Bible-based, Jesus-thumping version of Christian, religious CBT, basically. Now, of course, if you had a Muslim, they got a Quran stomping, version with the recitation of the Prophet Muhammad, peace be upon him, version of religious, or Buddhist. They got a Buddhist version of religious psychotherapy from the Dhammapada, from the Analects of Buddha. If they were Hindu, they got the Bhagavad Gita, and from Lord Krishna and Arjuna, that Lord Krishna was trying to advise. Lord Krishna is actually God, descended to earth, advising Arjuna, who is in a war, fighting for truth, etc. And so that's the basis for Hinduism. And so that is what we use there. And for Jewish people, we had the Torah. We had both conservative as well as more standard Jewish. It's not Reform, exactly. Reform Judaism. We had a version of all of that. And whatever their religious faith was, that's the version we used to strengthen the faith, to see if that didn't help the depression. Okay, so that's what we did there. Compared to standard secular psychotherapy. Now, these people all had to be kind of religious or spiritual to even get in the study. They had to be, because there was a 50% chance they were going to be randomized to this religious therapy. So they had to be at least a little bit religious. Although, actually, in this study, the group was not all that religious. In fact, if you compared their profile to the religiosity of the U.S. in general, it was actually about 10 to 20% lower. So even though it was in the South here, it was actually less than America in general. But partly because people who get depressed, they're having a hard time, and many of them may have lost their faith, or are struggling with it. So in any case, but we include everything. Plus, only half of them were from North Carolina. The other half were from California. So California isn't all that religious. Not
Those Adventists are though.
Those are Advent. Well, that's a good point.
I saw a documentary on that.
Yeah.
About their long lifespan.
Yeah. Well.
Around Loma Linda.
That makes sense, but in general, I grew up in California. I'm a Californian. I did work, though, for an Adventist physician in Lodi when I was a teenager. I swear. And now, believe it or not, Lodi Memorial is now an Adventist hospital. I just found that out. That's where I was born. And it's funny because I'm working with the Adventists right now in the Adventist Health Study. I'm the scientific guy who is actually measuring changes as they try to integrate spirituality into patient care in the whole system. This is the largest Protestant healthcare system in the United States, maybe the world. And they are now making a real effort, because they're faith-based, to integrate it. So I've helped design that study, and we're assessing them at baseline 1 month and 12 months after they get involved. These are physician outpatient practices. 500 physician outpatient practices. And even though they're connected with Adventist Health, only like 10% are Adventist. Everybody else is something else. Including Muslim and Buddhist and Hindu physicians, because there's a lot of Muslim, Buddhist, Hindu physicians out there. And so that's happening right now as we speak. In fact, that's why I've actually been writing the baseline paper for this study. This includes physicians and what we call spiritual care coordinators, usually a nurse. And what happens is the doctor takes a spiritual history and then kind of passes it on to the spiritual care coordinator, who then connects the person with a chaplain or, a pastoral care person who can address their spiritual needs related to their illness that the physician identifies. So that's the system that we have in place. And we've actually got videos on our website, 5 of them, 45 minutes long, for physicians, nurses, chaplains, on how to do this. It's really a multi-million-dollar study by the Adventists, together with Templeton funding. And so we had a Harvard-trained medical media specialist who created these 5 there. If you need CME, actually you can get CME for it too, but you have to pay for the CME. To watch the videos is completely free on our website. So I'll maybe talk a little bit about that in a moment. Okay, but this is this psychotherapy study. I was saying, North Carolina and Los Angeles. Okay, so here are the 5 kinds. And if you're interested in, exactly what you do with these various kinds of religious psychotherapy, the manuals are up there too. The workbooks, everything's for free. All you got to do is go to this website. So our website is a really good source for lots of free stuff. But I'm charging you $5 for this book, okay? But it's got my autograph in it, okay? So that makes it a whole lot more worth, since it's got my autograph in it, And this is a book. It's going to be a bestseller, okay? Now, so far in the month of April, and it just came out April 1st, it sold 3 books. Now, I'm telling you, though, it's headed for somewhere big. And you all are going to start this movement. Okay? So, anyway. Okay. Now, the results of this study. And we're going to talk about the results. So, basically, here are the results. So, this randomized clinical trial, severity of depression. This is baseline. This is over 24 weeks. The trial lasted for 12 weeks. Basically, they did about the same. They did about the same. The therapies. Now what this actually, the religious therapy did a little bit better, but not much. I mean, it wasn't even statistically significant. The what's called the effect size, okay, effect size was 0.10. So that's like nothing. But in any case, they at least did the same, and the religious CBT did better among those who were more religious. That was significant. There was an interaction between group and treatment. Level of religiosity at baseline and group. There was an interaction showing that those who are more religious, who got the religious psychotherapy, did better than those who were very religious and got the conventional. Now part of this makes sense. It's not earth-shaking. But you have to understand, remember the first slide I was showing you about Sigmund Freud? for decades. They have said that if you bring up religion in psychotherapy, the patient is going to do worse. They've been saying that forever. And that's why they avoid it in psychotherapy. This study clearly shows that if you've got somebody who's even a little bit religious, that they do at least as good. At least as good. If you're focusing on religion. So that pretty much disproves, based on a randomized clinical trial, what many mental health professionals have considered to be, gospel based on the writings of Sigmund Freud. So that's why this is an important study and why it's also published in a good journal. Okay. All right, so that's that. Now, actually, if you had a particular genotype, now we also measured, and we're getting a little bit scientific here, but we measured the genetic polymorphisms that the people had related to the serotonin genes. Okay, basically, when people take an antidepressant, they're called serotonin reuptake inhibitors. They want to make serotonin more available in the brain because we know serotonin is low in people who are depressed, anxious, so you want to raise it up with antidepressants. That's how they work typically. Prozac and all those kinds of drugs. So we measured the particular forms of the gene that people had. Of these various, there was the serotonin transporter gene, the serotonin receptor gene in the brain, all of these serotonin genes. And people in the population at large have different forms of these genes, some of which make people more vulnerable to depression because it lowers serotonin availability or transport. Okay? So if you had the CC genotype of the serotonin receptor gene, then you did a lot better with religious psychotherapy. Significantly better. The p-value there is less than 0.01. Now, what's interesting about this particular finding is that the effects were strongest in those who were not religious. So if you were not religious, you had this genotype, you got religious psychotherapy, you did a lot better than if you got conventional psychotherapy. So that was interesting as well. That's in the Austin Journal of Psychiatry. Now, in terms of, there are also some physiological changes that we found among those, who got the therapy. They had lower adrenaline levels, adrenaline, epinephrine, norepinephrine, those kind of things. Lower levels in the urine over the course of the studies. You can see. Here's the levels of epinephrine in the urine, actually, and they go down more quickly with the religious CBT compared to the secular CBT, and that's close to significant. It's not quite significant. Yes.
Did these patients have any different amounts or types of medication on board?
Yeah, they had a whole. They were all varying in amounts, and you're right. We didn't. To try to control for medication use, we collected the data, but we didn't control for it in this analysis. But we figured that since it was randomized, you got a pretty good chance. And when you looked at the baseline samples, that they were almost identical in each group because of the randomization process. You would think that the types of drugs they were on would be randomized across the groups. So we kind of assumed that. But to be exact, one should have measured some of that. So that's a good point. Okay, so that's that. And now, in terms of optimism, they did a lot better if they got the religious CBT. So there was an increase in optimism, and that got published in the in Depression and Anxiety. That's now out. That just came out just this month, in Depression and Anxiety. So religious CBT, higher on optimism, which is good because it might also help explain a major study. This is a huge, huge study coming out in JAMA, and I'm really not even supposed to talk about this. Let me first ask, is there anybody that's going to report anything in an article, in a newspaper? Okay? don't do it, please, because I could lose my job, because it's supposed to be a confidential review of some of this literature that's coming out, okay, by JAMA. So this is a major journal. They found among 90,000 women, 90,000 women, that the likelihood, white women, in this particular study, actually they've showed stronger effects in black women, but for white women, 90,000. This is a huge study. 15 years, 20 years, prospective, 1996 to 2014, almost 20 years. Prospective. They found that suicide rate was one-fifth in those who attended religious services at least weekly. So it was one-fifth. It dropped from 7 per 100,000 years down to 1 per 100,000 years. This is an incredible finding from Harvard. The group at Harvard by a doctor there who he's a full professor in statistics. This is a statistics professor, not like a medical doctor or some psychologist. This is a professor of statistics who designs new statistical methods at Harvard. He's the first author on this paper. So this is very exciting. They asked me to do the editorial on it. So hopefully that's going to be out probably in the June issue of JAMA. Okay, so this might be a reason why, and this is what I put in that editorial, why women are not committing suicide as often, because it gives them more hope, more optimism, even if they're depressed. So anyway, okay. So we're now doing a study. We're hoping to do a study. We're looking for money to do a study. Now that earlier study cost $1.4 million. We got most of that from the Templeton Foundation. We have a new study we'd like to do among veterans and active duty military with PTSD. Because we think that the moral injury that occurs when people are out there in combat and are in bad situations, you know, having to shoot maybe a civilian or a child because they're walking up to them, they got a coat on and they don't stop, and you know, they don't understand English, hey, stop. You think there's a universal language that says stop, but they don't stop. They come at them. You know, and here they got all their buddies around, so they kill them. They got to do it. They got to shoot them. They got to shoot that 9-year-old kid. Sure, that's their duty, but it leaves scars. Scars. You know, or if you have to, your best friends in the whole world, you know, that you're depending on, they get blown up, and you have to carry their arms back or take their, you know, carry their head back, collect their body parts. You know, this is traumatic. Very traumatic. Or killing anyone. Killing anyone, there's a cost to that. There's a cost to killing, even the enemy. You can bury it temporarily, but it comes up later on. Especially as you get older. Because most people can push it away. Push it away by staying busy. Work, you know, hobbies. But you get older, you get ill, you get sick, you get disabled, and it starts coming back. The moral injury. We think that moral injury is one of the key factors that maintains post-traumatic stress disorder in veterans and active duty military. Okay, so we have designed a spiritually oriented therapy for moral injury. And we are trying to get support for that. Okay, so we're trying to do we figure that, you know, you can kind of see the model. Killing, violence to others, witnessing violence, not being able to protect, morally compromising position, rape, torture, you know, all of that. That sets it up, transgresses the moral code. There are people who are religious and those who are not religious. Those who are religious are going to have a lot more moral injury of the religious kind. Religious struggles. God, why? You know, God, why me? Why did you allow this to happen? They're going to lose faith. They feel, well, I don't believe in God. What kind of a God could allow this? And then there's the psychological injury. The guilt, shame, self-condemnation, feeling betrayed, loss of trust, unable to forgive, loss of meaning. And We think that it's all kind of overlaps. And that's what's maintaining PTSD, depression, anxiety, substance abuse, sleep problems, relationship problems, headaches, chronic pain, physical disability, and unemployment. A lot of consequences of PTSD in our soldiers, in our veterans, in our active duty military that are the reason why we're all able to sit here together and not worry somebody's going to disband us because we're talking about religion in here. It's our military that assures us the freedom to sit here and assures the freedom of many people in other countries around the world. And these people are coming back wounded with this moral injury, and we're basically not treating it. The remission rate's only 20% in PTSD. That's with all the meds, all the psychotherapy, secular psychotherapy. 20% go into anything close to full remission. So we think we can improve on that. But we got to raise the MONEY.
What do you mean by the dotted line from non-religious to moral to religious?
Well, we think that, for those who are not that religious, there's going to be less of this. It stands to reason. You don't believe in God, then, you're not going to be struggling with God. He just doesn't exist. So, but to some extent, these individuals have still been raised and grown up in a Judeo-Christian culture, if they're in the U.S. So it's still going to affect their values and moral principles. So we figure, okay, we might, in fact, be dealing with some of this as well, even in those who don't acknowledge it. Yeah.
Dr. Koenig, one
Yes.
of the things I like about this is that the military, and I'm an ex-officer military,
Really?
yes, and is that there's a denial about the moral injury, that if you've done this for country, there shouldn't be a moral injury.
There shouldn't
Yet
be.
There is a moral injury.
There is. It's just inevitable. Yeah. Yeah. Yes.
This sounds like this would be something that people would be able to use for adults with childhood sexual abuse.
Agreed. Because this moral injury occurs whether you're the victim or the perpetrator. You start thinking about stuff and you feel guilty about whatever. So it doesn't matter. So absolutely. And in fact, we're just exploring right now. We're doing a few pilot studies basically for free. I'm trying to get volunteers to do these studies. It's a challenge. But we're doing a study among women veterans in particular. We're expanding at the VA up in Durham. I've got one person who's interested in particular in that. So he's doing some qualitative interviews to maybe lead up to a study that might involve women, military, who are, victims of, all sorts of things, when they're serving. So anyway, okay. So this is a lot of potential, and we're just hoping to do a pilot study to see whether it's going to work better than conventional secular what's called cognitive processing therapy, which is the current treatment for PTSD. Okay, so what about physical health? Quickly here, I'm running out of time, and I'm almost, but we're having some questions now. Okay, so don't hesitate to ask some questions here. But what about physical health? We've been talking mainly about mental health, and many people want to know, okay, well, does this make any difference with your physical health? So let's look at that. Yes, it actually probably does. Now, there's not as much research in that regard, but it looks like the majority of studies, 63 studies, found significantly lower blood pressure among those who are more religious. Lower blood pressure. And the majority find that there are, in general, better cardiovascular functions among those who are more religious. Now, that doesn't mean if you have cardiac problems that you're not religious enough, okay? It just means that in general, there is better heart rate variability, there is less cardiovascular reactivity, those kinds of things that predict heart attack and stroke and those kinds of things. They just seem to be less. And consequently, it's not surprising that there are fewer heart attacks. Fewer heart attacks in general among those who are more religious. And so those are all main studies in peer review journals. Here's a study in cardiology. You know, they compared this, not Christians. These are 10,000 Jewish men in middle age in Israel, followed for 25 years. Those who were more engaged in the Jewish religious practices, were going to synagogue, you know, worshiping in the home, and etc., they were 20% less likely to die of a heart attack during this 25-year period. Pretty significant. Now, here's a study out of New Hampshire. Is anybody from New Hampshire here in the room? I'm going to say something nasty about New Hampshire, so I just want to be sure, you know. So New Hampshire has the record for the lowest church attendance. They have all 50 states. I think now it's Vermont, but it was a couple of years ago it was New Hampshire. So not much going to church going on there. But if you're older and you have heart disease and you live in New Hampshire, time to go to church. Based on this particular study, because this study, this was at Dartmouth, came out of Dartmouth. You know, Dartmouth is in New Hampshire. They found that the likelihood of dying after open heart surgery among older adults was actually 14 times greater. The odds ratio, for some of you who understand, the odds ratio was 14.0, which is an astronomical increase in the likelihood of dying among those who had low religious coping and low social support. With that was a deadly combination. And a lot of those people got their support, since they were older, from a religious organization. So if you were not in a religious organization, didn't have that social support, and you didn't use religion to cope, you were 14 times more likely in the next 6 months after open heart surgery, after controlling for the biological predictors, that's severity of disease, you know, ejection fraction, all the medical stuff, controlling for that, the odds ratio was 14.0, which, as I said, is pretty impressive. Okay, and not surprisingly, now, all-cause mortality is lower among those who are more religious. There are 120 studies that have looked at this. These are older studies. There are a couple of studies from Harvard now circulating around in journals that have some very interesting findings. But in any case, 68% found greater longevity. And if you looked at the higher quality studies, 3/4 found greater longevity. So it's a difference in whites, it's about 7 years based on national samples. Those who attend church weekly or more compared to those who don't attend at all. African Americans, it's 14 years. So an African American who does not attend religious services at all will live in the United States to an average age of 66. Okay, that's in demography. That's a little older study, 1999. If they attend church at least weekly or more, the average age of death among African Americans is 80. So that's 14 years difference. So again, you know, these are not subtle findings, and it seems like, you know, medicine is trying to hide these findings. You don't hear about it. You don't hear about, you know, anything like this. So anyway, so here's the relationship across all the studies between religion and health. So here's, let me explain this. So here are the number of studies. You know, look at the number here. They're like 2,000, 2,500. These are all quantitative. Okay, again, these are not qualitative. No qualitative studies, no stories, nothing. Just numbers. Simply numbers. And so these are the number of studies. These are the findings. This is based on the handbook, you know, the Oxford Handbook. So there are a few studies that found complex results. Complex. So people who read the study, looked at the findings, basically couldn't figure out what they reported because it was written so confusing, you know, you couldn't. So they were complex. Okay. So then 250 studies find that those who are more religious are sicker NG, negative. Significantly sicker. More depression, more disease, more heart attacks, everything worse. 250 studies. And significantly so. So now this one in parenthesis means there was a trend. Not significant statistically, but a trend in that direction. So here are the studies that found mixed results, depending on which aspect of religiosity was measured. Maybe if you measured church attendance, you had a positive association with better health, but if you measured prayer, there was a negative association, worse health, something like that. Mixed findings, and significant. So there are about 250 of those. Now there are about 200 studies finding a trend towards a positive relationship with better health. Okay? And you all have these printed out, right? So you got the punchline. This is pretty good. If these are the positive, significant findings compared to those, with no association. So you got that. Usually I try to not have this slide included so I can surprise you, but it didn't work this time. That's all right. So here's how we explain it. This is what Duke does in their free time. Complex models to justify all the money that the government is giving them, basically. So here's to try to understand how this works. We want to understand why are religious people healthier and live longer? Is that all that obvious? Many people would wonder why. So here's a reason. Here's trying to put it all together, make sense of it. The source is belief in attachment to God, we think, in the Judeo-Christian Islamic tradition. This is the monotheistic model. I've got models for secular humanism and also for Eastern religions, but I suspect that most of you all are of the Judeo-Christian Islamic tradition here. So I'm going to present this model. They work very similar, believe it or not, across the faith traditions, and even among secular humanists, it works similar. Not quite, but... So belief in attachment to God. So these theological virtues, faith in God, hope in God, love of God, all of that is nurtured within a faith community, right? And then it's expressed in terms of public practices, attending religious services, scripture study groups, prayer groups, whatever. Private practices, praying by yourself or reading scriptures, whatever. Religious commitments, levels of religious experiences that one has as a consequence, and religious coping. So all of this. So this comes out of this attachment to God. That then affects our decisions that we make, our lifestyle choices, our health behaviors. And it encourages these kinds of psychological traits or virtues. In Sunday school, what do they tell you? Forgive your neighbor. Forgive people, right? Be honest. Be courageous. Be self-disciplined. Be altruistic. Be humble. Be grateful. Be patient, dependable. This is what religion teaches us to be, to do. We want that to be in our children. That's why we send our children, to schools that will train them that. And because we know that those who have more of this have more of that. They're happier. They have more friends. They have stabler marriages. They generally just have more social connections. They're less likely to become depressed or experience any kinds of negative emotions. When you're forgiving, honest, courageous, self-disciplined, love your neighbor, humble, grateful for what you have, are patient with others, and are dependable, that just naturally results in that. And of course, if you make good decisions, and you don't live a wild and crazy lifestyle, and you behave yourself in terms of your diet and what you're eating and your exercise and all of that, you don't drink too much, that's going to affect this too. And this, we know, affects that. These are the natural healing systems in the body that prevent disease and result in faster recovery. Your endocrine system, your immune system, your cardiovascular system, that's what heals. And of course, that's responsible for your health and your longevity. Now, all of this is grounded on your heredity, your genetics, how you were raised as a child. You know, you didn't have anything to do with that. You may have something to do with this, but you didn't have anything to do with that. You know, you don't, and there's some evidence that religious involvement, spiritual experiences, have some genetic predispositions. So some people are just more likely to be religious or spiritual because of their genetics. Nothing to do with their own decision. Now that's a very small part of it, we see, because religious involves very complex behavior. Genetics probably only explain a very small proportion or tendency towards. But there is still that there. You can see the complexity of this relationship makes it very hard to conclude if somebody is depressed or sick that they're not religious enough. Very hard to conclude that, to do this kind of reverse thinking. That, you know, if you were just religious enough, you wouldn't be depressed. You wouldn't be sick. You wouldn't be disabled. You just prayed more. That doesn't work that way. You know, you don't know what their genetics are. You weren't there in the womb with them, you know, or there when they were being raised. You have no idea what kind of environment that person came out of, or what kind of degenerative disorders that they have that might lead to that. You don't know what their brains look like when they were born from a parent that may have, you know, been through a divorce or been, you know, through an unhappy time during the pregnancy, may have used drugs or alcohol. You don't know any of that. How can you conclude that because they're depressed or anxious? A lot of times, my practice, the most religious and spiritual people are the sick people. Those are the ones that are the most religious, the most spiritual, you know, because they're really fighting the battle, you know. Okay. So that's that. We're now trying to understand the biological mechanism of why. And we're going right down to the cell level, actually to the DNA level. I was talking a little bit about DNA earlier, but this study involves caregivers, women caregivers, and religious involvement and telomere length. Telomeres are at the end of the DNA of the chromosome, right at the end of the chromosome. They are non-coding. I think I have, do I have some of this? Yeah, there it is. Here's the chromosome. Remember this from biology? All the cells have a chromosome. It like guides what the cell does. And so it's the genetic material. And when it replicates, now here's the DNA. This is the telomere. This is the telomere. It's at the end. It doesn't include any of this stuff. See? That stuff's important. That's the genome. That's coding for proteins that make us who we are. So this doesn't have any of those. See? The reason why is because every time the cell divides, a little part of the chromosome gets eaten off. So this thing gets progressively shorter with increasing age as the cells divide. The telomere is shortening each time. When it shortens to the point where it starts eating up that's it. That's the end of your life. So what we know is that telomere length is related to age. We also know that telomere length is related to stress level. That the higher the stress level, for the longer the time, the faster the telomeres shorten. We know that. So if religion helps people to cope, might it affect the speed at which telomeres are shortening? See, that's the hypothesis. So let's look at the findings. We had 251 caregivers. That's the first time anyone has looked at this. By the way, this morning I got a paper that is now in press from a colleague that has replicated this on a national sample, a population-based sample. The finding I'm going to show you. Okay? But you can see here that in our study, actually the person whose lab we used got the Nobel Prize in Medicine in 2008, Elizabeth Blackburn. So we used her lab to measure the telomeres in these caregivers. So here's the telomere length, and you can see that with age, in our study, this is our sample, the telomere lengths are going down with increasing age, as you would expect. So the data is behaving the way you would expect it. Now the question is, does religious involvement affect the speed at which these telomeres are shortening, and therefore explain why religious people live longer? Okay, so interestingly, now this is published so I could show it to you. Who has the longest telomeres in this particular study? The least religious people. The very least. These are caregivers who are really not religious. These are caregivers who never pray, never reach for... Now, how many caregivers do you know that never pray? Family caregiver, somebody who's severely disabled. They never pray. They're not associated with the religious affiliation of any kind. They don't go to church. They are very unreligious. They have the longest telomeres. However, look at this. If you drop that 10%, that bottom 10% out, there is a very nice, statistically significant relationship between religious involvement and telomere length. So my advice to you is that if you're a caregiver, you better be really not religious. Or you better be very religious if you care about your telomere lengths. Okay? There's no middle ground here. The middle ground, you get spit out of the mouth, right? And that somewhere says somewhere in some scripture somewhere that, right? We got some. I know we got some pastors in here. The chaplains. What? Revelation. Okay. Anyway, I don't know where it's at, but it's in there somewhere, I hear. So this is the first study to report this. But the second study is now in press by a colleague in Arizona, actually. He just sent me the study this morning. I was so excited about it because he did not find this. They did not find that. They just found that. There is a progressive, statistically significant increase in telomere length by religious attendance, frequency of prayer, reading holy scriptures, etc. in a sample of about 1,800. Okay, so this is population-based, random sample in the community, prospective study over time. That's what's coming out. It's in social science medicine. It'll come out soon. So there are lots of applications to clinical practice. You know, many patients have spiritual needs related to illness that influence their satisfaction with care. Religion influences coping with illness, affects the patient's emotional state. Religion affects important health-related behaviors and likely influences medical outcomes. Religious beliefs influence medical decision-making. Lots of stuff that has clinical relevance. You know, beliefs influence the decisions of doctors and nurses. We know that too. But we don't talk about it. Nobody's talking. It's like don't talk, don't tell, or whatever, you know. It influences compliance with treatment. It influences, and not only that, but the JCO. You're all familiar with JCO, the Joint Commission for the Accreditation of Hospital Organizations? That's why you're being paid, basically. Why you have a hospital here, why you're being paid. Because JCO accredits it, and you can then get money from insurance companies, from Medicare, etc. JCO requires that you respect and honor the cultural beliefs and practices of patients. One of those beliefs is spiritual beliefs, and it specifies that in the versions of the manual. I actually just got the manual, paid $1,000 to get it online. In all the mental health care, all the addiction stuff, and of course all of the hospice stuff. I mean, that's required in it. That's one of those things, and it explicitly says the spiritual and religious or religious beliefs of patients. That's explicitly in the manual. I actually did a search of the manual. Now that I have it, it's the 2016 January version. Searched it, and there's all scattered throughout that the hospital version. and even the outpatient version, but nothing like the hospital version. It's got it throughout it. Beliefs, attitudes, cultural, spiritual, throughout the whole thing. So, I mean, you know, if you're planning to have an initiative to do this, great. You're just abiding by the requirements that JACO has said. But you know, we don't do this. I mean, nobody's doing this. Nobody's doing this. You know, they're not getting docked for it, typically. But there's no hospital. Duke is certainly not doing it. They're not taking a spiritual history on people. Oh, yeah. What's your denomination? You want to see a chaplain. That's it. You know, that's Duke Hospital. So that's Duke Hospital. That's where, you know, the research is coming out of is Duke Hospital. They're not even doing it. So it's not surprising that nobody else is doing it. But we need to start doing it. I mean, we need to start doing it because it's good for patients' health. It's good for providers' health. And it's required. So what else do you need? What else do you need? Anyway, okay. So all we want people to do is take a spiritual history. We want the doctor to do this. We want the doctor to take a brief 3 questions. That's all we ask. 3 very simple questions. This is what we're doing in the Adventist Health Study. 3 questions. You know, talk with patients about these issues. Don't avoid them. Respect, value, support the practices of the patient. This is patient-centered. We're not trying to evangelize. We're not trying to bring them to their knees and confess Jesus is my Lord and Savior. If that happens, that happens. But we're not trying to do that. We're trying to just acknowledge what are your beliefs. How can we support those beliefs in helping you cope, feel better, be more hopeful? How can we do that? This is just good medicine. This is what used to be called good medical care. Yes?
But if increasing religiosity has such a positive effect, why wouldn't it then be incumbent on medical professionals to encourage, in some way, increasing religiosity?
Well, that's actually, some people have said that, but you're in a pluralistic healthcare system. I mean, you can't quote get away with doing that. You can't. I can say that flatly.
Even with research.
Even with research, you can't, because you've got providers across the religious spectrum. You've got patients across the religious spectrum. What you can certainly argue is that you can address patients' spiritual beliefs and support them. That's at a minimum. That's like a no-brainer. Anybody challenges you on that, you know, just, I don't know, you just point it out in the JACO manual, you know what it says. But that's a minimum you can do. But you can't really prescribe it. You can find out, do you have any, or do they say no? Say, okay, well, what gives your life a sense of purpose and meaning, and how can we support that? You know, you're always patient-centered, always. You're not pushing nothing. You're not trying to make people feel guilty because they're not religious or spiritual. You never do that. We don't need to be doing that to people who are sick. It's an abuse. I call it abusive. You know, you identify their beliefs. You're very sensitive in identifying them. You support them. If they have any spiritual needs of any kind, you connect them with somebody trained to do that. Typically, I don't recommend, you know, you just say, okay, well, how can I help you solve your religious, spiritual dilemmas? Because we aren't trained to do that. You know, there's people who are trained to do it. And those are the ones who are the experts. You don't like, family physician doesn't do open heart surgery, right? Family physician takes the blood pressure, you know, and maybe prescribes a few things, and etc. I was a family physician. I never did open heart surgery. You know, it's because I'm not trained to do it. And, you know, some of these spiritual dilemmas, as you know, with the patients face, you know, they're sick, they're praying, nothing's getting better, they're losing their loved ones. You know, these are complex issues. Struggles with God. I feel deserted by God. Is God punishing me? I have patients deeply religious, evangelical patients trying to convert me, you know, when I see them. You know, I'm already converted, so I don't have to be converted, but they're still trying. I'm not pure enough yet. You know, so I get them every time. They wonder whether God is punishing them. They ask me that. They say, I feel like God is punishing me for my past activities. When I was a kid, when I was a teenager, I'm being punished. This pain is not going away. It's been there for years. I can't stand it. I want to die. Please, Dr. Koenig, give me a reason to die. Give me, help me to die. And I say, nope, I'm not helping you to die. In fact, I'm bringing your whole family in. And I want them to tell you how much they love you before you kill yourself. Fine if you kill yourself. That's all right. But you're not going to do it until your family asks you all the questions, knows that you're going to kill yourself, and tells you how much they're going to miss you and love you. I did that with this patient. I did that. He's still alive 5 years later. Now his pain isn't any better. Not a bit better. In fact, if anything, it's worse. The doctor explicitly, I actually saw the patient like yesterday. And I read the note from the chronic pain doctor. It's a long note. This patient's pain is resistant to all narcotic analgesics. Spinal cord stimulators are not indicated. This is a neuropathic pain syndrome. There is nothing we can do to relieve this man's pain. And he's got guns in the house. And he has had suicidal thoughts, and we're referring him to Dr. Koenig, of course. Dr. Koenig is seeing him. When I saw him yesterday, I said, this is what I told him. I said, okay, now I understand, that you have the pain, like the doctors are saying there's nothing more they can do. And he's in pain while I'm telling him this, I say though, but and you got guns in the house, and I know you're not going to get rid of those guns. I know we've tried before. You wouldn't get. No, I get. But if you kill yourself, I'm not going to. That's okay, but don't shoot yourself. If you want to step out in front of a car, do that instead. That's what I told him. I'm kind of joking with him at the process, because I know, and he knows me. I mean, this is a very deep Christian man, and but he's right at his edge. I'm trying everything possible, every kind of creative way possible. I gave him the book. I gave him my book yesterday. I did. I figured, what else am I going to do? I got him all maxed out on antidepressants. He's got every kind of. He's on 600 of Lyrica. I don't know if you all know Lyrica. If you ever taken like 50 milligrams of Lyrica, you're going to be sleeping for days. Okay, he's on 600, just to give you a sense. And that doesn't even help that much. Really doesn't help that much. The pain is so severe that, he just spends most of his day in bed. He's a young man. He's like 50. I've seen him for almost 15 years. I've been treating him. 15 years. This way. I mean, he's been this way. Anyway, so that's basically it. Here's a spiritual history. Do your beliefs provide comfort? Are your beliefs a source of stress? Do you have any beliefs that might influence your decisions concerning your health care? Are you a member of a faith community? Is it supportive? So this is out of JAMA. This is actually JAMA published an article I wrote on the spiritual history. This is right out of there. Here are the videos. You got the website there. Okay? You can go there for free. Conclusions. Religion is easier to measure than spirituality, so most of the research has to do with religious involvement. Religion commonly used to cope with chronic medical illness. Associated with less emotional disorder, greater well-being, less substance abuse, greater social support, better health behaviors. So consequently, not surprisingly, it's related to better physical health, greater longevity. It's time to begin applying this research into clinical practice in sensible ways. It's just time. It's time to be doing this. But it's got to be sensible. It's got to be sensitive. And in a compassionate way. And in a flexible way. You don't want to make people uncomfortable. But you do want to identify a person's religious faith, and if it's helpful, support it in any way you can. In any way you can. So we have a free e-newsletter that I write every month. This one's free. Won't cost you $5. free. All you got to do is sign up. And you get the latest research. I summarize it every month. And information about different resources, books, tapes, videos, lectures. I'm pretty around Duke, because there's other groups at Duke, not just our group, that's doing a lot of very, very interesting work in the Divinity School and in the Medical Center in these areas. That's all in our e-newsletter. So all you got to do is sign up for it. There's our website. That's where you sign up for it. Sign up for mailing list. Right there. You put your email and you sign up for it. And here's our religious CBT study. That's where all the manuals are for the religious therapy. Then we have a new tab that says videos, CME videos. That's where all the videos are. And, we got the latest research under publications, and we have all of our newsletters, all of them, for years, under publications, under Crossroads. So you can go back and look at some of the research. If you want to, come to our workshop, you want to do research. Well, we have a workshop in August, 5 days, where we take a 2-year postdoc, cram it into 5 days. Very intensive study of this whole topic. We've had people from Johns Hopkins, Harvard, professors come to this. We've had pastors from North Carolina, Eastern North Carolina, Western, with a high school education come to this. You don't have to have any or no requirements. And people from all over the world come to this. And we have rabbis from Israel. We have imams and actually Islamic theologians from Egypt, from Saudi Arabia, Middle East, Turkey coming to this August one. Not from Saudi, but maybe Saudi. In fact, the other year we had a psychiatrist from Stanford who's developed for Muslims a whole group thing that's actually President Obama is giving her an award in the next couple of weeks or months. She just announced it. She's one of our students there in the workshop. So it's an incredible array of Christian, non-Christian people that are absolutely passionate about this topic. And, so if you're interested, there's my email address. And there's the book. Up there it says, new book. You Are My Beloved. Really? And so that's what the book is about. And it's got, it's short, 24 chapters, a couple of pages each chapter. You are my beloved. Kind of, where did I get that idea from? Bad stuff is happening in this world. Lots of bad stuff. Why does God allow that to happen? Does God exist? Now, none of this is scientific, by the way. There's not one iota of science in this book. It's all just, stuff that I've kind of thought about, kind of, out of my personal life and my patients. Some research, but it's really not. It's mainly based on scriptures, the Holy Scriptures, from the various traditions. Mostly Christianity, but I've got chapters on Islam. Does God love Muslims? Does God love Jews? Does God love Hindus? Really, this book was written for veterans. Written for veterans and active duty military with PTSD. That's why I wrote it. As we're starting this intervention, we're actually going to use the book in the intervention with the spiritually oriented CPT. And, it talks about a lot of things. The cause of evil. Why is there evil in the world? And then, how do you, what if you don't feel God's love? What about that? What are the causes for that? How does God love us? How does He do it? How do you go about maintaining the experience of God's love? How do you do that? And for patients, I think the patients I see, boy, this book is really, really for them. Anyway, it's good. And it tells a little bit of personal stuff, too. I kind of talk a little bit about my personal life in here, too. Because it is a personal book. It's a very personal. It's nothing like the 41 books that I've published. The Handbook of Religion and Health. It's not like that. It's very personal, not scientific. It's for people. It's a sharing kind of who I am to people. Patients. Anyway. So that book is available, $5, and cash or check. That's 50% less than what you're going to pay for it online, which is like $7.50 online. But only 3 of those books have sold. So again, depending on you. Okay. Here we are at 12 noon. So thank you very much.
Thank you.
Thank you so much, Dr. Koenig, for coming out to Claremont. The timing of today's program really was like the piece of a puzzle fitting into a very full puzzle. I looked at his speaking calendar and availability, and he was all over the world and all over the country for the last few months and getting ready to travel extensively again. And I found this little window of opportunity which worked perfectly with our schedules, and really a perfect strategic timing with Faith Health Gaston being launched on May 1st. So I'm really excited about that. Most of you do know me, Lisa Murasadea. I've talked to most of you about faith community nursing or Faith Health Gaston, and really the integration of faith and health here in Gaston County, and how we continue to really work hard to encourage faith communities to collaborate on projects. And I just wanted to bring your attention before we break for lunch on a couple of different opportunities that are available. If you are a registered nurse, if you know a registered nurse, have someone in your congregation who might be interested in learning more about this professionally, I'm bringing an educator here to Claremont the last week of June. It's a 4-day workshop course called the Faith Community Nursing Foundations course. It allows a nurse to practice this recognized specialty. The course itself is 4 days. It offers 38 contact hours, and it's $380. I do have some scholarship funds available. The requirements are a commitment to serve a community, a faith community here locally. So I have literature on this on the back table. If you think you want to take it to someone or have them call me for more information, I would love to chat with them about that. I also have a handout about Faith Health Gaston in its most simplistic terms. I think most of you may be familiar with it, but for those who are not, it's a movement of compassionate care that is being really spread across the country. Faith Health NC is Dr. Gary Gunderson's project through Wake Forest Baptist Health, and I've been working closely with him and developing a program for here in Gaston County called Faith Health Gaston. It's partnering the compassionate strengths of congregations with the medical expertise and health of health providers and the community resources. And so we have a program starting again on Sunday, helping patients who are being discharged who are 65 and older with certain diagnoses who don't have a support network once they get home. And so could you only imagine being discharged, having overcome a crisis, not fully stabilized from it, and not having anyone to support you? And so what we are doing is connecting volunteers with these patients to potentially provide them with a ride for a follow-up appointment to a healthcare provider, maybe provide a meal, a reassuring phone call, just something to show them that they're not on this journey alone. And so if you have any desire to learn more about that, I have some cards, again, on the back table with some information that you can be contacted to learn a little bit more. We have upcoming trainings for that, and really a worthwhile cause to reach out to folks with that. Contact information is back there. The books are back there, $5. They're signed. Really a blessing to have Dr. Koenig in our community today. Lunch is available back there. We're going to have an open discussion with Dr. Koenig. For those of you who may not have registered for lunch ahead of time, we do have some extras available. You're welcome to purchase one today. So again, we thank you for coming here to Claremont Regional Medical Center for this wonderful program. We thank Dr. Koenig for traveling from Duke today for that. And we just look forward to great things happening and further integrating faith and health here in Gaston County. Thank you.